So Darren mentioned guidelines, Jess. What should we know as of early 2019 now? What's changed in the guidelines? What's the Cliff Notes version of how the GLP-1 agonists relate to guidelines?
Yeah, so there's been a major shift in our guidelines when we're looking at the ADA guidelines or the ACE guidelines of the clinical endocrinologist. And, we still have that background therapy with metformin as being that primary first-line agent, unless there's a contraindication or intolerabilities to metformin. But really what we're seeing with the GLP-1s is after the patient is no longer controlled with metformin is when you can immediately jump in with the GLP-1 options. With that being said, if we have a patient that has cardiovascular concerns, if we have a patient that has heart failure concerns, if we're trying to promote weight loss or to limit hypoglycemia, these are all great agents that you could immediately go to after we've explored the metformin therapy when you're looking specifically at the guidelines.
So I'm still thinking metformin to start. Mm-hmm. But if that's not working, or I've got these ancillary special conditions or comorbidities, I might be looking straight towards these types of therapies.
Yeah. I think one of the biggest things that end of last year when the new ADA guidelines came out, and especially the ADA EASD consensus report, I think in the ACE guidelines, GLPs have been favored for a long time, and we all would agree on that. I think now, they've taken the approach that if a patient has established cardiovascular disease, because some of the agents that we're going to talk about today have what we call cardiovascular outcomes data. And because of that, now at least the ADA, I think it was late, but I think better late than never, where they come out and say, after your first line of metformin, the question that you need to ask yourself as a clinician is, does the patient have established cardiovascular disease? And if so, they want you to use these group of drugs that have this data. And the GLP class happens to be one of the two classes that has this cardiovascular outcomes data.
So that's an interesting concept, and we're seeing that more often now where we have a treatment for diabetes, but it's the outcomes associated with an ancillary or neighboring disease state that are really affecting where it is in the line. That gets to your 8 systems, and so are we going to see GI data and other types of systems data, the effects of say GLP-1s coming out, do you think, in research? So if we've got cardiovascular, what about other organ systems?
Yeah, I do think so, but I think probably more what we're going to see in the future is time in range. Okay. So one of the things we're looking at is hypoglycemia as a cardiovascular risk factor. And the number of hypoglycemic episodes a patient has really puts them at a risk. And so we want to minimize that, but at the same time we want to minimize the hyperglycemia episodes as well. So when we look at patients, we're looking at how much time are they within a normal glucose range. So rather than the organ system that we're looking at, I think we're looking at about which medication will keep you within a neutral normal range for the longest period or the greatest period of time.
Yeah, so time and range seems to me to be a little bit more advanced version of proportion of days covered.
Yes.
Right? I mean, that's what we're thinking about it in terms of how are we doing on a timeline, and we don't want to see a lot of variation, but so the idea being is the exposure is time out of range, high or low.
Exactly.
And how are we managing patients so they're in that magic range, just like the little mountain guy on Price is Right.
Yeah.
Right?
Yes.
And Troy, one thing that I'll add is I think the other shift that's happening now is I think we're focusing on treating the whole patient and not just the disease. And to Sue's point, we're looking at some of these beyond A1C metrics, such as time in range and hypoglycemia. But the other thing that is also happening with this class of medications and others is they're starting to look at diabetes-adjacent diseases. And so you're looking at this in GLP use and the impact from a renal standpoint, in NASH, in obesity. In obesity, there's already a medication that's on the market. And so when you think about, I always use this line for when I'm giving a presentation to ask the audience, like, what do you think folks with diabetes die from? And 8 out of 10 of them are dying from cardiovascular causes. And everyone's like, well, you did an entire talk and you're only talking about cardiovascular data. We haven't even talked about the glycemic. But at the end of the day, that's what I call the needle mover, right? If you want to move that needle, you need to start focusing on what's actually the population is suffering from. And so I think that's why now there's more of a holistic approach in looking at just not the disease and looking at that whole patient.
Right, and it's not just the adjacent disease, it's also the untoward outcomes. So when we think of diabetes, poor outcomes, we're thinking of lower leg amputations, blindness, chronic kidney disease, other problems associated with diabetes. But they're problems in and of themselves and conditions that have to be treated in and of themselves. So what's interesting to me, those stats that I frequently go back to when we're writing for Pharmacy Times, 70% of the nation's healthcare costs are borne by patients with 2 or more chronic illnesses. 83.2% of the nation's prescription fills are for patients with 2 or more chronic illnesses. Do we need to be thinking of therapies not in silos based on condition, but what does the whole treatment plan look like for that whole patient, since so many of our patients have these comorbidities?
And
right?
I think we also have to look at the obesity factor. You know, how stupid is it when we say, oh, you have diabetes, here's a medication that will cause you to gain weight, but we want you to lose weight. I mean, we set the patient up to fail. It's not that the patient failed, the medication failed the patient. So, you know, to Darren's point, we want to set the patient up for success by focusing on the whole patient. And you know, Jess, you mentioned, of course, that we're not only looking at cardiovascular, but we're also looking at weight loss, low hypoglycemia. You know, so again, something that will address more than just those glycemic markers.
Well, and I think what's been nice is now with the ADA being more in tune, is almost being prescriptive. Those guidelines actually help us as clinicians, because oftentimes when you're looking at payers or when you're looking at making those recommendations to those primary care providers or to those specialty services in endocrine or whatever it is, we have those guidelines to support something we have always been doing since the data has been coming out. So we have always tended to practice the evidence-based medicine, and then you finally have a guideline that supports and demonstrates that. I think that's going to allow for us to treat that patient as a whole.